We are making a little progress with reducing unwarranted variation. And the reason for that is a number of initiatives that have been going on over the years, which have really worked together to attempt to improve this problem of unwarranted variation. But at the outset, I'd like to say that actually the variation still exists, and we still do quite a lot of work on this. But the initiatives that started off were really with the very old national peer review process that took place in England, where services were reviewed by peers and factors identified that might improve both the structure of the services initially and then eventually performance of the services. And then due to a great deal of effort, the National Lung Cancer Audit was started. And you can't underestimate just how difficult that is. We take it for granted now, but the whole lot of work that went into getting the data set together, making sure that the data verification was as good as it could be, and then analysing it was very, very important. And that really, for the first time, showed the extent of the influence of the hub and spoke model we have on the variation in care. So since then, there have been quite a lot of initiatives that have been around producing care quality indicators, things like dashboards, making sure that people have a performance target of one sort or another. And they've gone from quite a lot of performance targets to just single performance targets now. And I'm not sure that's the best way to do things. One of the focuses of my presentation is going to be about what can we do that's more than this. And back in 2017, the Clinical Expert Group for Lung Cancer published an advice to alliances, which was about commissioning guidance. And it's essentially said two things that are very important. One is that we need to have a more global responsibility for care. So if large centres have got lots of facilities, they should have some sort of responsibility, direct responsibility, for centres that may be less well equipped in terms of personnel and equipment, and they should have more of an outreach service or even an assistance service for those units. That was number one. And number two was to clearly define the amount of clinical time and expertise that's required to deliver a lung cancer service. Now, initially, in our document in 2017, it just defined one specific time for respiratory physicians, and that's been used widely by different services to make sure they get their respiratory physician numbers up as much as possible. This new document goes much further. At the request of the members of the Clinical Expert Group, we've now produced clinical times for all of the specialties, and actually factored in things like lung cancer screening and genomics and various additional jobs that a number of professionals have to do. So I'm hoping this will be adopted by NHS England. At the moment, they're a bit slow to adopt, despite having their own variation group that started a couple of years ago. So hopefully this presentation will be a stimulus to BTOG members to try and push for that.